In this episode of Hope in the Pipeline, I'm going to be interviewing Dr. David Weed, our pediatrician and principal investigator with Preferred Research Partners here in Little Rock. Hello and welcome again to Hope in the Pipeline. I'm Dr. Paul Wylie, neuropsychiatry, sleep medicine, and clinical trial specialist, and the medical director of Preferred Research Partners in Little Rock, Arkansas. Dr. Weed is new to Preferred Research Partners, and so I'm delighted to introduce him to our pipeline audience. Welcome again to today's podcast, and today we're going to talk a little bit about pediatric attention deficit and hyperactivity disorder, problem that really creates a lot of difficulty starting these days, diagnosis around age 4, as early as that, and there are some medications that have been approved and are currently in some clinical trials to be approved for children as young as 4 years old, and then, of course, all the way up through age 18. And then we know that a certain percentage of people who have ADHD as kids and adolescents and teens, the ADHD persists into their adulthood. And creates some problems and difficulties for them then. So I think it's really important in the development of a child, the healthy development of a child, the successful psychological development of a child, succeeding in academics and succeeding in their interpersonal relationships and just their relationships with their family and their siblings and their friends, that ADHD be diagnosed as quickly as possible, and then that people get on some medication to be of help. And so we'll talk a little bit about that today. Okay. So I guess the first thing, if you could tell us a little bit about, from your experience as a pediatrician, about some of the problems kids have with inattentiveness and concentration difficulties and what you've seen there.
Sure. Well, so I've been in practice for almost 30 years. And I've frequently seen kids that are in the office for this reason. The problems that ADHD can lead to with attention are many. I see a lot of difficulty with organizational skills. The kids that have ADHD struggle with all levels of organization, of where they put things, where they have written down things, misplacing schoolwork, and organization also as pertains to how they structure their day and their priorities, and remembering what tasks are at hand. So that's a big factor. That it really interrupts the flow of their day and causes a lot of trouble at home and in the classroom.
I've had some kids in particular that may come in with some self-esteem issues.
Yes,
and the self-esteem issue has in part to do with other kids recognizing that they have some trouble with organization and concentration. Right. So, a group project get assigned and you've got 3 or 4 people that want to work together. And, some folks are downcast about the fact that one of the individuals in the group has ADHD that may keep them from being a successful partner.
Right.
So can you talk a little bit about how ADHD has impacted self-esteem in the patients you've worked with, and how do you respond to that?
Well, I see that a lot. I see that kids with ADHD struggle with their schoolwork, and it causes a negative attitude towards school, or a defeated attitude towards school. They feel like they can't succeed or have a harder time succeeding than their peers, and that leads to feeling defeated. I think they feel like they aren't smart enough to succeed. It hurts their self-esteem, and that just creates a cycle where everything gets worse. Their self-esteem is poor. They don't like school as much, which makes them not as interested to try and pay attention, and they feel like they're going to do poorly on tests in advance, which is a self-fulfilling prophecy. And it just causes a snowball effect that really affects their schoolwork badly. I think it affects their relationship with their peers as well. I think that a lot of those kids realize that they struggle with getting along, and that some kids may even try to steer clear of having contact with them because of that. And so they might not try as much to make friends or talk to people because they know that people might not want to talk to them as much. Yeah. So I think self-esteem is a huge factor with that.
Wow, huge lightning as we're recording today. Yeah. So, and aside from the inattentiveness and difficulty with concentration that people affected by ADHD have, some people just have that area of problem. Particularly females tend to be more affected by the inattentiveness, and I think sometimes that shows up as a failure to perform on tests or other assessments at the level that would be anticipated based off the known intellectual capacity of the individual. So there have been teachers who've said, well, Tammy, or whatever her name might be, is a very smart little girl and has all these skills and efforts, but then on tests just does not perform. And so people start scratching their head as to kind of what's getting in the way of, in particular, test performance when someone may have some fantastic reading skills or things like that, right? If in a non-distracted environment. When we talk about ADHD, which, attention deficit and then hyperactivity disorder, we can also focus on the behavioral component of ADHD, the hyperactivity. So, which tends to be a little bit more common in boys than girls, although not exclusively by any means. So can you talk a little bit about the hyperactivity component and its impact?
Sure. I think that's the symptom a lot of people think about when they think about ADHD because it's more visible. A lot of the kids that just have the inattentive component can fall through the cracks because you don't see it. You
underdiagnosed.
You don't physically see it.
Absolutely.
The hyperactivity component is usually pretty easy to see, and kids that have that struggle with, of course, staying still, staying seated in their seats at school or at home, fidgeting, which is a distraction for them and people around them, excessive talking in class. It really makes it, if they're already inattentive, that level of activity that they struggle with interferes even more with their ability to pay attention. It again, I mentioned the snowball effect of it building on itself. That makes it even worse. And it makes it difficult at home as well. I think parents see it a lot at home with difficulty in completing tasks at home, required chores, getting ready for school in the morning, trying to settle down for bedtime, things that really affect the quality of life for them at home as well.
Yeah. The hyperactivity part, I think, seems to get kids sent to the principal more often than that. And so, that can have an effect on kids' self-esteem as well, too. And some of the hyperactivity leads to some intrusiveness at school, at home, just the interruption of others' activities. And they're trying to focus, and the affected child really can't resist jumping into the middle of the activity. So there's that component. I was at a restaurant a few weeks back and got seated at a booth, David. And so there was a family behind me in the booth, and so my booth kept shaking and shaking and shaking. And eventually I had like a 6-year-old leaning over my booth, kind of looking at what I was eating and talking with me, and then coming around and then jumping up and down by our table and crawling under our table and things like that. And so the parents were a little bit mortified about their child from that standpoint. And I said, well, if there's anyone who understands kind of what's going on that you could be sitting next to, it would be me. And so it was my opportunity to talk with them a little bit about it, that if they're struggling with this, they might want to go see their pediatrician, and there's, plenty of help out there. And that's kind of what I do, is trying to help kids with that. So it shows up at home for sure. And sometimes in public, where was I? Oh, Home Depot. The other day, going into Home Depot, and all of a sudden I see this kid running across the entrance to Home Depot toward the door, and their parents running after the child. And so, that can be kind of another manifestation, is the impulsive jumping ahead in an activity, or impulsively jumping ahead in line, things like that. And some of that can be kind of dangerous. It's not like there wasn't cars coming from that standpoint. So it's hard sometimes for those parents to have confidence that their child's going to stay next to them, or, that if they hold their hand, their child's not going to impulsively, pull away and run ahead. So some safety aspects to it too. You talked, and obviously this is a topic near and dear to my heart as a sleep medicine doc, but you mentioned about the impact of ADHD, particularly hyperactivity component, on sleep. And so can you talk a little bit about what parents come to you and describe as far as difficulty in getting a child to bed?
Sure. The parents describe it, and so do the kids. It's described a lot as that their mind won't turn off, that their mind's racing. They mention things like getting stuck in a loop, thinking about things, and just cannot rest. Their mind cannot rest. And then once they try to go to sleep and can't, they're awake. And then that leads to, I think, some of the hyperactivity behavior creeps in. They don't want to stay in bed. They don't stay in bed. And so that affects their sleep dramatically, as well as the parents. And that also will impact them the next day, because without sleep, it makes focusing and concentration even harder. But yeah, that's a really common concern with parents.
Yeah, I always, as a sleep medicine doc, try and break down the difficulty sleeping into some specific areas. As you pointed out, with some kids, it's a hyperactive brain. I'm having trouble thinking at night, and so sometimes we have to teach them about how to settle their brain down before bedtime. And often I use the term cooling off your brain a little bit, and that was kind of purposeful, because actually brain cooling has been shown to help some of those individuals have some less hyperactive thoughts. So we're going to get into that in a moment, maybe about some behavioral component treatments for ADHD. So there's that part. And then there's the hyperactivity part, which really has to do a lot with kind of motor restlessness, just the inability to be still. And some of those kids don't necessarily describe so much their brain running away with them. It's just the motor restlessness. Some kids have both, right? And so I think that's why it's very important for a pediatrician or any practitioner that treats ADHD to try to figure out exactly what type or flavor of ADHD there is. And, in the diagnostic books, there can, they list 3 subtypes of ADHD, inattentive type, hyperactive type, or combined type. And I always chuckle at that, David, because I'm thinking, well, in my mind, it's like ADHD is like Baskin-Robbins ice cream. There's 31 different flavors.
That's great.
It's because some kids have sleep problems, some kids don't. there's just a lot of nuances with the ADHD. Some kids have more aggression with their ADHD, and so that's another nuance. Some kids, it affects them more in terms of having a lot of passivity, and that people look at them as kind of disengaged when they're not. Maybe they're in some internal thought pattern. So I always feel like it's important to try and subtype ADHD as much as possible from that standpoint. So ADHD, significant problem. How many times a day in your practice do you think you might see ADHD, or maybe per week?
Well, I see probably 8 or 10 patients a day that are there for that reason.
Wow. Okay.
And I get asked about it probably an additional 8 or 10 times every day. Now, not all the kids that whose parents ask about that probably have ADHD. They may have symptoms that are similar, but I mean, frequently, very frequently.
That's really frequent. You maybe see 30 or 40 people a day, perhaps, within your practice. From that standpoint. So, we're talking about almost 50% of your daily activity, which is really significant.
Yeah, spend either seeing patients or talking about it.
So you and I go back practicing medicine 30 years each at least, right, from that standpoint. And so I can think back that, 30 years ago, what did we do for the problem? And there wasn't a lot. And from that standpoint, and wasn't necessarily even recognized as being a problem. But some of the first treatments that, came out were and it was, it wasn't that these were directly tested in a clinical trial. It was physicians saying, we got to try something to help with these kids. And lo and behold, paradoxically, we had some docs that figured out that stimulant medications actually had sort of the opposite effect in people who have ADHD. So you want to talk a little bit about, going back to when we first started working with ADHD and stimulant medications and some of the challenges that presented?
Sure. So when I was first in practice, or even before, when I was an adolescent and had some friends or school acquaintances that had struggles, the primary medication was Ritalin, or methylphenidate, is a generic name for it. I think it was and it can be effective. One of the difficulties was that the medicine didn't last very long, so it had to be dosed multiple times a day.
Yeah, 2 or 3.
Yes. Yeah. So typically before school, around lunchtime, and sometimes after school.
Yeah. And then there's the hassle of arranging that with the school.
Right. It's the hassle of doing it. The kids didn't often like the stigma of having to go to the nurse in the middle of the day to take their medicine. And it was forgotten sometimes. I mean, even with adults, the more medicine has to be taken, the more it's forgotten. It's just human nature. So it's not going to be as effective if it's not taken. So that was, I think, a real stumbling block with the generic Ritalin then. I believe also caffeine was used anecdotally some to help with focus. That's why adults drink coffee in the morning, or I usually drink Diet Mountain Dew instead of coffee, but same principle. And also another one of the early medicines was Adderall, which it's a different ingredient as Ritalin, but the same overall schedule, given 2 or 3 times a day. And so it had the same challenges.
Yep.
I think the biggest progress over the years until real recently was that they began to come in extended release versions, different brand names like Concerta or Vyvanse or Adderall XR, medicines that could be given once in the morning and would last ideally 10 to 12 hours. Yep. So at least the midday dose wasn't necessary.
Yeah.
That helped compliance and remove the stigma of being the person that has to take medicine at school.
Yeah.
That was a big benefit, I feel like.
Yeah.
And then
David, timing was before we go into recent, because I always felt like I struggled with it. Timing, right? And first off, what was the timing of the first dose? So your initial impulse is to give timing of the first dose to make sure it's in before school starts. But that's not when ADHD starts. ADHD starts when trying to get ready for school. So just the disorganization, the moment someone wakes up in the morning, just, parents tend to pull their hair out for some kids, trying to get them organized enough to get to school. And so then you have to start thinking about whether or not you give the medicine upon waking. And I actually had some kids, I remember that immediately upon waking, it was just a disaster. The parent had no way of corralling them. And so I would actually talk to the parent about timing their first dose, because the medicine would take too long to get in for that particular child. Right. So, well, maybe wake them up an hour before it's actually time to get up, have them swallow their pill and then go back to sleep at that point. So then when they wake up, the medicine's on board and effective. Right. So the timing of that first dose, critical, right? Then that affects the timing of the second dose, because now all of a sudden maybe it's wearing off in the morning versus right at noon or lunchtime. And so then how do you get the child to, get access to it, in the middle of class? Right. And you don't realize it's wearing off at that time, and you try and extending it to lunch, but then that makes it miserable maybe that they don't do as well in the class that's occurring an hour before lunch. It's one thing if it's PE. Right. It's another thing if it's English and sit down and write this composition, type thing. So that second dose. And then, as you pointed out, when we don't have the long-acting compounds, often a third dose was necessary. It would show up in things like, they can't stay organized enough to get on the right bus. Right. Or, 45 minutes before school's out, they just have a problem, and that last class is almost just wasted at the end of the day. So need another dose in terms of getting home. Or it's, they have an extracurricular activity that's at school that they go to participate in, but the child isn't listening to the coach. So now you have that dose from that standpoint, right? So how do you time that to where the child can be successful in their extracurricular activities? And sometimes I had to think about a fourth dose, which is a little bit scary to think about, and because it's off label, right, in terms of how often you dose. But on the other hand, you treat the individual patient, and a dose that late that would be given in the afternoon, you have to worry about it interfering with sleep. Will it be gone by then? But, part of the problem is the parents will say, well, all this is great during the day, really doing good at school, but they've got homework assigned at night. And so by the time they do their extracurricular activity right after school, and then they go home and now it's time for homework, they've got no dose available to them and not on board, and they can't be organized enough to do their homework, right? So then you try and give them a medicine to help with homework time, maybe a lower dose or, and the timing of that. But then you have to be delicate about that to make sure it doesn't interfere with bedtime. So I always looked at it as an extremely complicated treatment regimen if you really get highly individualized with people, right? Yeah. And so then you talked about some of the longer acting medicines become available, and they were longer acting, absolutely more than the 2.5 to 4 hours you might get out of a dose, but not necessarily long acting enough to make physicians happy to where it's a one dose all day, takes care of you from 7 in the morning till 7 at night type thing, right? So even long acting ones had to be supplemented often with another dose of a shorter acting one, later in the day. That then created challenges with insurance companies trying to get that approved. And there were some patches maybe that came out, right? We were talking about different forms of medicine that made it a little bit easier for a longer acting type thing. So it's a challenge both back then and now. Right. So I wanted to touch base a little bit more on that. And you were getting ready to talk about some of the things that have come along since Ritalin and methylphenidate or Adderall or amphetamine salts. So please.
Sure. Well, one treatment that became available was Strattera, which also I believe the generic is atomoxetine. And it's a once-a-day medication that once it reaches a certain level in the bloodstream, shouldn't wear off, so it should provide benefit all day. Another advantage of that medication and ones like it is that it shouldn't affect appetite, which is a big or can be a big side effect for the stimulants. When we have kids on stimulants, we watch their weight gain and growth charts really closely. We watch all of our patients' growth charts closely, but when they're on stimulants, it's more of acute concern. Mm-hmm. But that not really applicable with Strattera. Another similar medicine like that, I believe it's in the same class or similar class as Quellbry, which is more recent. Mm-hmm. And I believe is being tested or soon to be tested now, I think, in even younger kids.
Yes, we did some of the clinical trials for development of Quellbry from that standpoint, and it is being looked at now in the 4 to 6 year old age group. So absolutely, yeah. So,
that's right.
Yep. That brings up another issue, which is, your job as a physician in caring for your patient and in caring for the family is not done necessarily when you find a successful dose of medicine that gets them through the day. As you point out, just when you think you've got a good regimen settled on, you look at the growth chart and you realize that they're losing weight or they haven't grown or things like that. And so, that's where some of the newer medications, I think, may be having a little bit less effect on growth. But, that brought up the whole thing about drug holidays.
Right.
So, I'm sure in your practice, you would maybe think about bringing people in sometime around April or May as school is getting ready to be let out. And then you got to think about your summer strategy for dosing. Right. Yeah. So you want to give a drug holiday over the summer, maybe allow some growth return, and kids do bounce back. But, you think you've got that settled down. The parent says, well, but we're going on vacation for, a week or 2 weeks to here. And what am I going to do during that time? So sometimes you have to work on, even if you'd like to give them a holiday during the summer, you've got to, work with a week or two, or they got summer camp, they can't successfully be in summer camp. So it really complicates things. And so sometimes that leads to switching drugs just to have to manage their weight. Yeah. And so we got Quellbry. Any other new medicines or other medicines out there that you're looking at or thinking about?
Not that I'm immediately familiar with.
Okay. Well, I know that for kids who have trouble sleeping at night, often another medication is required, right? And so wondering about your use of clonidine, guanfacine, things like that.
I've had good luck with clonidine. Patients tend to do well with that. Clonidine is a medicine that was invented for blood pressure, but shown in low doses, like ideally a 0.1 or 0.2 milligram dosage before bed, is very helpful for that. And I feel like it's safe. I don't see it cause any blood pressure problems in children, and I think it works. I really get good feedback from kids and parents that try that. Yeah. I sometimes use or recommend hydroxyzine at night to help with sleep. It's not specifically for ADHD. It's an antihistamine for allergy, but it's a very safe alternative, I think, that's helpful at times also. Yeah.
There are some kids I've taken care of that, have a combined, aside from their ADHD and their hyperactivity at night, they have such hyperactivity in the daytime. They may have some other complicating medical conditions in addition to their ADHD, where you really kind of have to settle their motor system down. And so sometimes use of guanfacine at night, very similar alpha blocker to the clonidine, but also throughout the day, sometimes for ADHD and settling some kids down. So we've got that as well. Wouldn't it be wonderful if someday through clinical trials or other research, we identified a blood test that we could check ahead of time to figure out what type of ADHD someone has genetically? I mean, we see the behavioral manifestations of it as practitioners, but if we would be able to figure out kind of what type they had genetically ahead of time, it would maybe really get rid of some of the trial and error process that I know you and I have gone through, where we've said, well, I'm going to start you on, Dexedrine or something like that. And then they don't respond. And you think, well, the last 8 5-year-olds I've treated have responded to dexedrine, but this one seems to respond to methylphenidate, or the opposite problem where we start people on methylphenidate and you run into people who don't respond to that, but strangely respond to the other medicine. So then you wonder what medicine might be most helpful at night. And so I would love for us through clinical trials and other research to be able to develop some predictive tests for ADHD to be able to genetically type what difficulty, someone has. Maybe even figure out genetically if someone's going to be prone to, struggling with their weight or other things like that. That would make practice easier. For sure. David, one of the things I've always appreciated about you and your practice partners is that you guys have a very comprehensive pediatric practice. And so I know you guys are not just focused on medication for treatment of ADHD. You guys have a behavioral program for ADHD. And so I thought you might talk a little bit more about that because important component.
Sure. So I do believe there are ways to help ADHD outside of using medication for it. I think behavior therapy is very helpful. Our clinic has had child psychologists and counselors that come to our office or that we can easily refer to help with that aspect of it. And I think it's very helpful. I think it makes the kids also feel somewhat more empowered and helps their self-esteem even more that they're able to make better decisions and help themselves and not feel as reliant on medication for it.
Yeah. The whole issue of, how do I cope with how I'm treated by others because of my challenges? How do I cope with how I feel about myself because of this challenge that I face? How can I be empowered to do some things to help with my own sleep routine, particularly as the child gets older? So you teach them some tricks of the trade. How can I stand up for myself at school? And I'm not talking with other kids, but how do I teach my teachers about ADHD and kind of assertively be in my requests for accommodations for extra testing time or things like that to help with my ADHD from that standpoint. So I know one patient I can remember had a lot of trouble concentrating during testing. And so the initial accommodation was to be in a quiet room or quiet area. And then the quiet room or quiet area ended up being close to the cafeteria workers, and that didn't work out very well. So, and being assertive enough to say, hey, I really need something better or different from the school to help in this area, I think is important. And, from a therapy standpoint, half of it's helping the child, and the other half is helping the parents, because how do I effectively and safely and competently parent a child with ADHD? Because inevitably your patients may be tested in some way or another, or you've got your own disappointments or things like that. And how do I assertively advocate for my child within the school environment? So I know that you've got therapists in your clinic that help folks work with that as well too. But what do the parents say to you when they're struggling with their child with ADHD? I know they look at you, with some desperation and say help, but then also how they react when all of a sudden you find a successful behavioral medication treatment regimen.
Well, they're initially pretty desperate. They're disappointed that their child's struggling and can see how it affects their personality and happiness. And when they come back in and things are better, it's amazing. Their mood is lighter. The kids are happier. The kids like school. A lot of the parents didn't think that really was ever going to happen or felt like it was unlikely. But it's really great to see a child come in who had been struggling before and didn't like school and didn't think they were going to ever really do very well at school, and come in and have that completely reversed. The kids liking school, being enthusiastic, enjoying learning more, making friends better. It's great to see that. Parents love that. I mean, I hear that a lot, and it's really rewarding.
Yeah. Teachers love it too.
Sure.
I mean, not only are teachers invested in the success of that individual child, but they're invested in the success of their whole classroom. And so their ability, I think, to give more effort to teaching and instruction overall versus time and effort spent in trying to maintain the organization of the classroom and the peacefulness of the classroom, I think, is important. So that's another big area for sure from that standpoint. So absolutely. Well, David, one of the things I'm excited to have you involved with preferred research about is obviously your pediatric background. And, we've got some pediatric trials for ADHD that we've done, and we've got some going on now. And so excited to have you involved with that process for sure. I think the pharmaceutical companies will look even more highly upon our research site to have a pediatrician involved in that process. And I think it provides comfort, I think, to the families and to the patients as well. So we're excited about that. And I haven't just got back from the American Academy of Neurology conference. There was some sessions there on pediatric ADHD and looking at it from a neurological standpoint. And I think they're working kind of groundbreaking stuff. So they're working on, I think, isolating brainwave patterns in ADHD. And so when I was talking earlier about, can we subtype ADHD? Can we do some genetic testing for ADHD? I never thought, maybe until these last few days, that we might get down to some of the testing we might do actually could be involved in looking at how someone's brainwave patterns are before and post treatment and optimizing things that way through the brain EEG, which would be a pretty amazing step from that standpoint. That gets to a whole level of specificity I never expected. So it startled me from that standpoint. It makes sense. It's just I'm glad we've got some folks looking at it from that standpoint. And then there's all sorts of research and theories and all different types of theories blaming ADHD on various things in our environment or other things like that. And there may be some environmental components to it, but we know it's definitely got a genetic component too from that standpoint. ADHD tends to run highly in families, right? Yeah. So in fact, I guess the most common scenario we found over the years is that mom or dad brings in their child to participate in a clinical trial, and mom or dad has had ADHD, and so they know how treatment was effective for them, or they know that they missed out on treatment and how much trouble it caused them, and so they want their child to participate, from that standpoint. So there's that, but gosh, if we could get to the point, and I know they're starting to try and take a look at whether or not we can isolate more clearly what some of the genetic inheritance patterns of ADHD may be, and are we able to predict that and maybe intervene a little bit ahead of time from that. So it's exciting things for us to look forward to, maybe some cool things for you and I to work on together in terms of clinical trials that way. So we'll look forward to the future. So
I do too.
Yeah. Well, folks, thank you for your time and attention today. As always, please like, rate, and review our podcast, which helps more people to find it and to learn from it. If you know someone who you think might benefit from viewing this podcast episode, please share it with them. As always, thanks so much for listening to today's Hope in the Pipeline, and we'll see you again next time.